Welcome everyone. This is GAL-3 staining of tumor biopsies as a companion diagnostic for the reversal of immune checkpoint inhibitor resistance. So this is the student team. We are greeted with Olivia Cashin, Hexandra Mijangos, Rodney Perkins, Irene Oliveira, and Abisola Abu. So just as a quick breakdown, our primary goal for this presentation was to explore the economic benefits of using a GAL-3 staining test as a companion diagnostic to guide the administration of immune checkpoint inhibitor therapy in cancer. In order to do this, we feel the best way to provide support for potential FDA validation and economic integration by evaluating the candidate tests that we have, incorporate new economic models, look at the cost effectiveness of these GAL-3 staining tests, and look at survival outcomes. So just a quick breakdown of how the presentation is going to go today. We're going to look at a diagnostic comparison, including the background on galectins and ICI, compare GAL-3 tests, and discuss important specifications. For our second objective, our ORR and dropout analysis, we want to define ORRs, review baseline ORR rates, and understand what dropout rates are. For our third, we want to look at the economic modeling of integrating GAL-3 staining into healthcare. So we want to quantify the quality of life gains and life year extensions. And we also want to justify the adoption of GAL-3 testing with regards to economics. Lastly, we want to look at the revenue recovery forecast by calculating the loss of revenue, project the potential revenue savings, and we also want to look at GAL-3's influence on the current top ICI companies, which would look at things such as efficient resource allocation and reduced treatment waste.
And how we set about accomplishing those four main objectives were a variety of accessible materials and methods. We conducted no experiments of any kind. This was an observational descriptive study, and our primary materials were internet, personal and library computers, and popular search engines like Google, Yahoo, PubMed. And the one that wasn't the most accessible was ASU Library, just because not everybody has access to that. But our goal was to not have any paywalls for our sources. The methods that we applied these materials with were a variety of research, information gathering, and analysis techniques, and project management tools such as Slack and Zoom for communication, and Google Suite products for documents, presentations, and spreadsheet data compilation to put all of our sources together and interpret this data in a way that supports our hypothesis.
Thank you. So we started by introducing what galectins are. So galectins are carbohydrate binding proteins that specifically bind to sugar molecules, be galactoside sugars, a type of carbohydrate found on many surfaces. These are general galectins, but in all, we have three groups of these galectins. Next slide, please. We have three groups. So we have the ones that are tandem repeat, and we have the ones that are prototypical. Then we have the chimera, which falls into the category of what we are talking about now, which is GAL-3. Why are we talking about galectins, differentiating galectins from GAL-3 from every other galectins? GAL-3 is the only one that its structure is in chimera type. It's the only one that has one carbon, one CRD. It's the only one. It's the only type of galectin that has N-terminal. And this N-terminal is the attribute that makes it so distinct from every other galectins, because this N-terminal possession made it to be able to go into any kind of biological processes. That's the difference between GAL-3 and every other galectins. Next slide, please. So after talking about GAL-3, we now want to talk about immune checkpoint, which is the issue we are trying to tackle concerning this research. Immune checkpoints, we have three major types. We have the PD-1, which is the program death. We We have the PDL1, which is the program death ligand, always as in mostly found on top of a cancer cell, a tumor. Let me put it that way. Then we have the CTLA4. So these immune checkpoints, we have established the fact that, yeah, there are immune checkpoints in helping out in for therapy concerning cancer. Nevertheless, these immune checkpoints are not functioning the way they should be. That is why we are questioning this. Next slide, please. So we came about after immune checkpoint, we came about immune checkpoint inhibitors. What are the immune checkpoint inhibitors? These are the monoclonal antibodies that block immune checkpoints or other ligands, effectively releasing the brakes on the immune system and allowing it to attack cancer cells. Normally, immune checkpoints are supposed to help out in attacking cancer cells. But because of the association between PD-1 and PD-L1, or PD-L1 and CTLA4, it inhibits their action, the role they are supposed to play in countering against tumor cells. That's the reason why immune checkpoint inhibitors were made. Now we have these immune checkpoint inhibitors, examples here on this table. I just gave a little example, which is ipilimumab, which targets CTLA4, pembrolizumab, which targets PD-1, atezolizumab, which targets PD-L1. How do they work? Tumor cells express PD-L1, yeah, and they interact with CTLA4 to hide, so that they can hide from the immune system to act on them. This is how the immune checkpoint works. Next slide, please. So this is the visual representation of immune checkpoints and immune checkpoint inhibitor interaction. Here we have the TCL, which normally when it sees cancer cells, the PD-1 is supposed to activate the TCL to help counter against the cancer cell. That is what the normal thing it's supposed to do. But right now, it doesn't do that because of the reaction between PD-1 and PD-L1, the PD-L1 ligand. Now we move down what the immune checkpoint inhibitor would help in disassociating the relationship between PD-1 and PD-L1 so that the T cell can see the cancer cells and attack it. So that is the essence of the creation of immune checkpoint inhibitor, which I mentioned, like ipilimumab, pembrolizumab. Next slide, please. Now, back to GAL-3 again in the picture. We now found out that even with the immune checkpoint inhibitor, we still have people not responding well to the therapy given to them concerning cancer. What is the cause? People suspected the expression of GAL-3 levels. This is part of what is inhibiting the function of ICI to function properly. So this is the pictorial representation of how GAL-3 tries to cooperate with PD-1, so that PD-1 will not allow ICI to work to function normally the way it's supposed to function, so as to destroy the tumor cells. So this is the structural representation. The GAL-3 stabilizes the interaction between PD-1 and PD-L1. It plays a critical role in tumor evasion, and it blocks ICI. It blocks ICI binding to PD-1, because if ICI binds to PD-1, it will make T cell to function, to play its role. But it blocks this ICI from binding to PD-1 to play its role. It suppresses T cell infiltration, hence it promotes tumor growth. Next slide, please. So what are the benefits of using GAL-3 as a predictive biomarker? Next person.
This is fine. Slide. So, okay. So with the benefits of using GAL-3, we have a few different ones, and I put 7 here.
So first, it can predict the ICI resistance. So when we have elevated galectin-3 expression, this, as Abisola was explaining, this expression inhibits the cytotoxic T cell activity and fosters an immunosuppressive tumor environment. It is also associated with reduced response to PD-1 and PD-1L1 in non-small cell lung cancer, melanoma, head and neck cancers, for example. Also support patient stratification. So for personalized treatment, this allows to identify patients that are unlikely to benefit from ICIs, and then they guide them towards finding an alternative or combination therapies that work better for them. This also enhances the clinical outcomes by aligning patients with most effective treatment paths. Also improve therapeutic effectiveness by avoiding unnecessary exposure to expensive and ineffective treatments, minimizing the patient risk for toxicity and psychological burden for failed therapies. Also enables a companion diagnostics. According to our research, ICIs cost roughly between $150,000 per patient per year, and galectin-3 screening prevents the wasteful spending on non-responders. The economic models show even limited exclusion of galectin-3 patients and leading to enormous savings. It also enables companion diagnostics in precision oncology. So galectin-3 immunohistochemistry is available and easy to integrate into the routine of other pathology workflows. And it's also compatible with formalin-fixed paraffin-embedded tissues and cost-efficient for large-scale use. It also promotes combination therapy innovation. Emerging evidence supports that combining the galectin-3 inhibitors with ICIs helps to overcome the resistance and also open pathways for novel drug development and expand the therapeutic options. It also aligns with value-based care for healthcare models by delivering more target care, improve patient outcomes, and supports efficient resource utilization. So that way we can strengthen the transition towards patient center, and also medicine can be more precise and more personalized. Next slide.
And how we set about demonstrating how useful galectin-3 tests can be, we wanted to choose a representative test because there's a pretty wide scope of those that are available. There are dozens of different protocols that people can use and a variety of different technologies, but of course they come with different strengths and drawbacks. So we just, for simplicity, chose 4 that were pretty different, and we chose our valued specifications like sensitivity, specificity, cost, and time. And we laid that all out on this chart. My teammate Irene will talk more on it, but it's important to note that on this chart, those values denoted with an asterisk, they represent data points that were taken as an average of a range, just to make it a really clear visual of what each test has to offer and what their strengths are. Slide, please.
Thank you, Olivia. So as previously mentioned, we picked the Clone-IC4 to be the best test, and to dive into details that made the Clone-IC4 the best candidate, as we took in consideration 2 critical metrics to assess the test accuracy, and they are specificity and sensitivity. A test with high specificity is good at detecting true negatives, and a test with high sensitivity is good at detecting true positives. And for oncology, diagnostics, an accurate test is crucial in order to detect the disease and start treatment as soon as possible, and also to avoid unnecessary treatments by detecting true negatives. And other factors that we looked at are resolution, reproducibility, test, result time, cost, and quantification. Based on these factors, Clone-IC4 presented the fastest turnaround time and at a reasonable price, which is around $375. I'll now look at the other tests, starting with the first one, galectin-3 IHC. It has a competitive sensitivity and specificity, but it takes 2 days to generate results. And now looking at the immunofluorescence test, it has a slight lower sensitivity, and it has a turnaround time of 2 days. And the last one, the LSB2, it has a specificity of only 57.5, which is not what we're looking for. So that's why we picked the Clone-IC4 as the best test to be validated by FDA as a companion test. Next slide.
And a huge unit of measurement that's important in this presentation is objective response rates. We've already given a big overview and background on how galectin-3 works, but galectin-3 status, knowledge of your galectin-3 status, can play a huge role in objective response rates, which can be pretty much defined as the percentage of partial or complete responses that patients experience in a treatment in a given time period, just usually a efficacy measure for cancer treatment. So if you have 100 patients taking this clinical trial, 20 of them respond a little bit, they see a little bit of tumor shrinkage, and 10 of them see complete tumor shrinkage, and then the remaining 70 see no reduction at all, your response rate would still just be that 30%. And the significance of this is that there isn't one cancer objective response rate, because cancers and the people that are diagnosed with them are highly unique, highly variable, and the current state of cancer treatment with ICIs being one size fits all is largely ineffective, as we'll demonstrate in the next slide, please. So this looks like a lot of data, and it is, but what you're looking at is the current state of ICI effectiveness with monotherapy and without screening, which we're trying to advocate for. We chose to represent this with a heat map, so those values looking more darker red represent relatively poor values, the orange to yellow, medium range, and green representing relatively good. But what you can see on this slide is at the very, very best, at 71%, which does not represent the majority, only 2/3 of those patients are seeing a response as a result of taking this expensive treatment. But for the vast majority of people, they can expect that over 2/3 of people are not responding to this treatment. And obviously, as we'll discuss further on, this is not only economically taxing, but taking ineffective and inappropriate treatment can get in the way of somebody finding the right cancer treatment for them. And time is really important, and quality of life is really important. And the role that galectin-3 knowledge has on this, as you'll see in the next slide, this is also a measure of objective response rate, and the only thing that's different about it is the knowledge of their high galectin-3 expression rates. So as you can see, the shorter lines in red at the top are the people that had high galectin-3 expression, and as we discussed earlier, that is a predictor of not responding to this ICI treatment. A lot of them are shorter because they dropped out, finding that they had no tumor shrinkage and a lot of times tumor growth. And the green lines representing people who tested negative for galectin-3 saw that when they stuck with the treatment, they were getting some significant tumor shrinkage. And there's absolutely no difference in these rates from the other ones as far as the biology of the patient or the drugs they were taking. The only difference was that whether or not they were aware of what their galectin-3 status was. And we'll discuss further on in this presentation that if this were implemented worldwide and across the United States, you could save a lot of patients time and money on personalizing their cancer treatment plan selection. Slide, please.
This table shows the clinical association between galectin-3 and ORR. Based on the table, most cancer have high galectin-3 expression, and its level tends to increase as the disease is progressing. There's ample evidence that increase in galectin-3 expression on the patient associated with poor survival and also for disease-free survival irrespective of the cancer type. For cancer types that do not have the data available for the ORR response, studies showed that high levels of galectin-3 is strongly associated with poor prognosis. That's why we observe that the response rate of the treatment tends to decrease when there are high concentration of galectin-3. The main takeaway of this table is that once the galectin-3 levels go up, the OR and the survival rate decrease. Next slide, please.
So while we're still talking about galectin-3 and objective response rates, we just want to chip it in that, fine, we're not neglecting those that are expressing galectin-3 in high rate. No, there are clinical trials going on behalf of them to like work against the galectin-3 expression. So far so good. We found out that we have belapectin, which is ongoing, still ongoing. I think they finished the phase 1. They've been approved the phase 2 of the clinical trial. But if you look at the table here, when those that had advanced melanoma were treated normally with just ICI, the response rate was just 33%. But in the clinical trial, when they tried with using galectin-3 antagonist, we can also see the response rate increase. This is giving us a positive, a good thing to go into, like really work for this. And for atezolizumab, yeah, which is the checkpoint inhibitor used here for NSCLC cancer. For ICI alone, the response rate was just 22 to 38%. But the clinical trial proved to us that with galectin-3 antagonists used for people expressing galectin-3, the response rate is 60%. Then we have for pembrolizumab, although we don't have, the trial is still ongoing. We're expecting the results at the end, before the end of 2025 to compare the response rate with using ICI alone without using galectin-3 antagonist. So this is the promise for those that express galectin-3 expression. They are not out of the nuke. They are being considered. That's why this table is presented here. Next slide.
My colleague has done a great job explaining the benefits of using a guided therapy. So all I have to add here is that by understanding how galectin-3 influences treatment response, we can develop strategies where we can target the galectin-3 directly, or we can enhance the anti-tumor immunity to overcome galectin-3 suppressive effects. And we can optimize treatment by considering galectin-3 expression. And lastly, we can also develop combinations of therapies that work in conjunction with galectin-3 targeting strategies. Next slide, please. This table shows the percentage of dropouts and time spent on ICI treatment before dropping out by cancer type. Galectin-3 expression is frequently elevated across a range of cancer types and is associated with resistance to chemotherapy, immunotherapy, and targeted agents. This correlates with reduced observed response rates and contributes to a notable version of treatment discontinuations. And dropout rates due to treatment failure on this table, it ranges from 10 to 62%, and it depends on tumor type and also on the treatment modality, with most patients discontinue the treatment within 3 to 12 months. And these findings underscore the potential of galectin-3 as a biomarker for treatment stratification and as a target for overcoming therapeutic resistance in oncology. And besides unsuccessful treatments, patients tend to drop out of treatments due to adverse side effects and also due to the high cost. Next slide, please.
So one of the biggest factors in getting these tests considered for potential validation would be the economics of the test, right? So we want to look at the implications for galectin-3 testing, which would be to identify those non-responders. As we saw in the spider plot, people who understood their galectin expression levels were able to take effective treatment and take out ineffective treatments, which saved them and the healthcare system money, right? So that recovers revenue for the healthcare system. Now, for some clinical and financial advantages of integrating galectin-3 staining tests, you'll see improved outcomes like the spider plot we saw earlier. You'll see more targeted ICI usage, which means that will reduce any medical waste for ineffective treatments. And it also reduces toxicity in non-responders who would not be taking these ineffective treatments, but also taking in things that they don't really need, right? So when we look at the economics of potentially integrating a galectin-3 staining test, we have to understand some key concepts, right? So galectin-3 can help to improve precision medicine and also reduce costs when we look at factors such as the ICER, which stands for the incremental cost effectiveness ratio, which is going to be a major player in pushing a galectin-3 staining test and promoting it to the FDA. So an ICER is a measure that shows how much extra cost is needed in order to gain one additional quality adjusted life year, a QALY, when comparing two treatments, right? So a QALY stands for quality adjusted life years, and we want to think of this as a score almost, right? So one QALY would equal 1 year of perfect health. That means that patient was not experiencing any side effects, illnesses, or things like that. However, if someone is living with an ongoing illness, they may not have one full QALY. They may have half a QALY, for example. So if someone has 2 half QALYs, then that does equal up to 1 year of quality adjusted life, right? So the QALY is going to tell us how much good the treatment will give us, whereas the ICER is going to tell us how much would it cost to add on to that, how much that good quality year will cost, right? So if you imagine buying a car, right, and it saves you 1 hour on your way to work, you want to see how much benefit with that 1 hour, like let's say if that hour saved time, is it worth the extra money? That's basically what the ICER does. We're looking at, is that extra year of better quality life worth the extra cost? And this is a quantifiable measure of the quality of life, right? So here we have an applied QALY for non-small cell lung cancer, and we want to look at this chart on the right, and this is going to be a very important chart when it comes to pushing why galectin-3 staining needs to be integrated into healthcare, right? So if we look at our groups, we have chemo only. So these are people who only take chemotherapy. The cost of chemotherapy is roughly $48,000 for 1.4 QALYs. Now, when we look at patients who are taking ICIs with no galectin-3 test, the cost for that ICI could be roughly $147,000, which would give them 2.65 QALY, right? But when we take a look at the ICER for that is going to be 79,200, right? So that is with no galectin-3 staining test incorporated. When we look at the next group, an ICI with a galectin-3 positive test, so these are patients who know that they are expressing galectin-3, we still have that same cost, but we can see that with that added galectin-3 staining test, they now have 3.65 QALYs, and their ICER value is $44,000. So that means in order to add another year of quality life onto this patient, it would only cost $44,000. Whereas in the previous group, it would have costed $79,000 in order to add on an additional quality life year. And we see even more savings when we start to integrate antagonists, right? So typically a galectin-3 antagonist costs around $60,000. And when we look at that measure and integrate that into our $147,000, we get a cost of $207,000. But when we incorporate that into our ICER values, we get $70,000 for an extra quality life year. Now, this is going to be important because if we look at group 3 and group 1, we are giving a patient more quality life for less money compared to having done no galectin-3 test versus doing a test and also incorporating an antagonist. Now, when we look at patients that have done an ICI with galectin-3, who have taken a galectin-3 test and come out negative, they have an ICER value of $39,000 and a quality of 3.9. Now, the main takeaway from this is that the galectin-3 staining test incorporation is going to cut ICER costs in half, basically, right? So when we incorporate a galectin-3 test, we are practically cutting the amount of money it takes to give this patient more quality life, right? So when we look at the benefit of ICI and a galectin-3 antagonist therapy, there are therapeutic advantages such as enhancing and extending therapeutic responses. We're rescuing those non-responders, and we're also increasing the qualities and survivalship potential of the patient. And when we integrate that, a combo therapy along with an antagonist, it helps to overcome that resistance, which is the main thing we want to do with the integration of this galectin-3 staining test. In order to support that precision medicine, we want to be able to find medicines such as pembrolizumab and the ones mentioned prior and give it to patients we know that are going to be effective, thereby eliminating any medical waste and any unnecessary expenses on behalf of the healthcare system. Also, using it as a companion diagnostic would help to improve patient selection. As previously stated, toxicity in non-responders, it will improve clinical outcomes in these responders, and the initial cost will be offset by reduced future therapies and also fewer hospitalizations and needs of the patient. Right.
Okay, so to predict the potential cost reductions from avoiding ineffective treatment, we have some takeaways after listening to Rodney. We want to avoid ineffective treatments, and we want to find the treatment that is more personalized for the patient and the one that is going to provide the most benefits for them. So when we were looking at this, when we were looking at this table, we're finding that what is usually the roughly amount of the IC therapy cost per patient annually by the different 20 type of different cancers that we have been researching in this project. And then we have the potential cost reduction by multiplying this by the non-responder rate estimated. So this is the one for each individual patient. This would avoid the high cost of ineffective ICI therapy. For example, some of them, well, depending here, I have some cost reductions ranging from $72,000 to $91,000 per patient, depending the type of cancer they have, and depending the ICI cost and the no-responder rate they have too. And galectin-3 staining identifies these no-responders, preventing this unnecessary treatment. Some of the targets that are for galectin-3 expression cancers are mostly prevalently found in colorectal cancer, melanoma, kidney cancer, cervical, Hodgkin, urothelial cancers. And this is where we can find or see the highest savings. Also, it has an economic value, and it can be seen in high galectin-3 prevalence, the low IC response, and the broad IC usage. And it also has this table base show that the higher savings, as I said right now here, the economic case for the galectin-3 testing shows biomarker guide, pretreatment screening maximizes value of expensive therapies. It strengthens also the support for routine clinical implementation of galectin-3 diagnostics and also aligns with payer interest. So we have more value-based oncology care. We have better outcomes, reduced waste, and more target treatment. And then estimating the high galectin positive patients excluded from ICI therapy. So in this slide, we can see, again, the galectin-3 prevalence according to each individual cancer type and the potential screen out that they can have. And I made this calculation estimating and the revenue loss for 1,000 patients, but it can be, when it's calculated globally or inside the United States, it can show billions of dollars in revenue loss and also savings for the patient. In this case, the purpose is that enhances the patient selection by identifying non-responders and to the immune checkpoint inhibitors. Also prevents ineffective treatment for all the patients with high galectin-3 expression. And as it shows here, one of the ones are colorectal cancer, head, neck, and some of them are higher than 60% in most of these cases. Also, when combining the data, we can say that annual cancer incidence in the United States is roughly 1.9 million new cases. And by seeing the ICI eligibility rates, we can also target those new cases, and then we can find out what are potential for screening out and what can be eligible for this treatment. Overall, we estimated 320,000 to 380,000 patients per year that can be screened out of ICI therapy due to this high galectin-3 expression. And this would reduce the exposure again to those ineffective treatments. And also they will save this money because there will not be wasting this money in a treatment that will not work out for you. Also optimizes the resources allocation towards the more suitable options. And it can be, as Rodney explained it before, by chemo, by target therapy, or the clinical trials. And also improves the clinical outcomes and drives precision therapy development based in galectin-3 resistant mechanisms. And by doing this, we can allocate better our resources and we can enable more precise, efficient, and strategic approach for cancer immunotherapy and health system management.
Okay, so as we've talked about, on an individual patient basis, knowing your galectin-3 status would be a huge game changer. But this also has ginormous implications on the broad scale. We wanted to take a look at what kind of economic impact for ICI treatment costs alone. This doesn't factor in things like the million unmeasurable costs that people diagnosed with cancer find themselves incurring, such as mental health services, transportation costs, alternative costs, so just ICI treatment savings. For the top 5 players in the ICI healthcare economy, we have Opdivo, Keytruda, Tecentriq, Imfinzi, and Libtayo. And it wasn't a simple answer to find a clear projection of how much of their sales would be redirected with galectin-3. We had to go in and find for those products the most commonly treated cancer types by those products. And we took a weighted average of the galectin-3 positive rates for all of those cancers to be that second column that you're seeing, average galectin-3 positive rate. And that's an important thing to use in this metric because when we're taking these annual sales that these companies see, we wanted to make the assumption that if all of these, for example, 56.2% of people who have high galectin-3 expression, if they knew that, they probably wouldn't be electing to take an ICI that wouldn't be affected for them. So if all of these people did not get their ICIs, you would get savings to the U.S. healthcare system and global healthcare system. In total, estimated just shy of $13 billion for the U.S. and over $25 billion globally annually. And again, this is just for ICI treatment costs. We wanted to go further and find out, as an estimate, how many patients are affected by this or could benefit from this annually. And we took these savings projections divided by the cost of the ICI treatment per patient. And we got just shy of 100,000 of American patients per year and shy of 200,000 global patients per year. Slide, please.
This slide shows the 5 top antagonist companies that I showed in the slide before, but this one, it ranks the companies by number of patients treated with ICI drugs. It also shows the pipeline and the marketing positioning for these 5 companies. So first one, we have Merck. He's holding the top position with Keytruda, and it's showing an aggressive expansion. And the one holding the last position is Regeneron with only 9,000 patients, as they focus mostly on innovations. And the other 3, BMS, Roche, and AstraZeneca, they be showing like a stable growth over the years as they focus on different types of cancers. Next slide, please. All right, so now moving on, now we're going to show how much we would be saving by implementing the Clone-IC4 test as a companion test for the ICI treatment. First, let's take a look at how much it will cost to implement the test. So on your left right here, we have a column a table that summarizes the cost. So the test itself would cost per patient in range $350 to $950. So it would be around an average of $650. And that's included on the procurement cost, tissue preparation, and also the physician interpretation. And now the row below, it shows the one-time implementation cost. And this would be around $1 million to $5 million. And this is to get the test validated by FDA. And it could take up to 6 months to have the test validated. And now moving on, and just so you know, this is a one implementation cost just to get a test validated. So moving on the right side, we have a table that shows the number of patients in the US and globally. So if every patient take the test, including the ICI positive patients and ICI negative patient, it would cost around $115 million to implement the test in the US and $223 million to implement the test globally. And that's considering the worst case scenario where we have to pay $5 million to implement the test to have it validated by FDA. Now looking at the graph below, even paying this value to implement the cost, we are still saving $12 billion in US, and we're still saving $25 billion globally. So the implementation cost is nothing compared to the net savings that we see by implementing this test. That's why we highly recommend to validate the Clone-IC4 test as a companion test. And moving on to the next slide. And also we have other costs that are not included on the previous slide. Like Olivia mentioned, there are costs to hospital visits, transportation, treatment-related complications, facilities, and that can be around $18,000 to $37,000 per patient. So also there are other benefits by implementing this test that's not just related to economics. So it's the patients. As mentioned before, we're doing a big reduction in the emotional stress to unsuccessful treatments, and also we're going to lower the toxicity-related expenses. And for our taxpayers, we're going to improve the healthcare system because all this money that we saw as the net savings can be implemented in the healthcare, which is going to make the healthcare more affordable for mostly taxpayers. And also for the pharmaceutical companies, based on this, they can create robust efficacy profiles in biomarker positive population, and also they can strengthen reimbursement arguments and regulatory positioning. Next slide, please.
Now, following the information that Rodney shared about quality in ICER, we have all the 20 cancer types, and we can see the difference between what's the benefit by omitting patients from IC treatment against the combination therapy. So when we have the objective response rate of monotherapy, sometimes it's low, it can rate between 15, 17, even let's say the highest can be sometimes 35 in this case. And then when we estimated that the combination of ICI with galectin-3 would be 90% across all the cancer types. And then we can deduct this from the monotherapy, and we'll find out that there is a substantial gain in objective rate response. So for each ICI agent that we can use, we will try to get a reference from them, and then we're gonna find what is the quality for monotherapy and the quality for combo therapy. And then as Rodney explained, the quality increases. Well, in this table shows how the combination therapy increases the quality of life for a patient almost 3 times more. And also, if we want to spend some more money to get this extra improvement, it is also cost effective. We can also get, when we're talking about the ICER, the price is ranging between the 15 and 18,000, but is more costly effective that if we only treat a patient that with monotherapy that is not working for them. So we know for sure with the therapy, combined therapy, we're going to obtain a good result, better quality of life, and we can extend it for a reasonable price. So this is pretty much what this table is showing. And the main key of this is the combination therapy is going to deliver better results for the health of the patient and also for the price you're paying for the treatment. So monotherapy is less efficient and less economical efficient.
All right, so now we're at the end of our presentation, and the main takeaway from this research is that the clone IC first preferred a companion diagnostic test due to sensitivity, specificity, low cost, and fast turnaround time. And second, detecting galectin-3 levels help guide therapy decision. It allows clinicians to select treatments with a higher likelihood of success. And also by integrating a galectin-3 staining test before administering ICI, the cost for one extra life year, it gets cut in half. And lastly, implementation of the clone IC4 as a companion test could save the U.S. economically around $13 billion annually and also $25 billion globally. So all these findings highlight how integrating a companion test is not only a clinically sound decision, but also is cost effective. So this research study aligns with the growing push for decision for the precision medicine, which is treating the right patient with the right therapy and also at the right time. So move forward, when we adopt the galectin-3 as a companion test, we can improve so much the cancer treatment. So thank you so much for attending. Please let us know if you have any questions.